Good morning, all of you, and chairpersons and my friends. Thank you, Debashish, for having me here. I'm really delighted to be in Calcutta, especially after the pandemic. And the topic given to me over the next few minutes, which I'll be discussing with you, is treating critical lesions below 2 kilograms. I'll be giving you a surgeon's perspective on this. When we are talking of low birth weight, the first articles, a series which came out from Stanford by Mohan Reddy, distinguished two varieties. One is low birth weight below 2.5 kilos and very low birth weight below 1.5 kilos. And we know that about 10 to 20% of congenital heart disease neonates are of these in this category, possibly due to prematurity and IUGR seen in these children. Now, can you get this thing away from this? It comes on the heading, I'm sorry, just a moment. Yeah, that's it. I think I fixed it. So let us ask ourselves a question, particularly to the surgeons. What is so special for a surgeon when you're handling these kind of small babies? One, they are not only small in size and weight, a lot of them are premature, of varying degrees of prematurity. And invariably, they have pretty complex lesions. And we all know from our experience, they've got a poor tolerance for cardiopulmonary bypass. They have longer ICU stays. And indeed, they test is the skill of the whole team in managing them to recovery. And particularly in our country, and maybe across the world too, these small kids are very prone for sepsis. Some of the common lesions which all of us encounter in these low birth weight babies are obstructive TAPVC. At least in my experience, that has been the commonest. Transposition of great arteries, conotruncal anomalies, arch interruptions, HLHS, and tetralogy pulmonary atresia. All of them are pretty severe and complicated lesions, and a few of them may be hemitruncus, vascular rings, etc. Now that brings us to a question: are we seeing more of this subset nowadays as compared to earlier? I don't know, but at least possibly because there are late conceptions, older parenthood. Fetal echo has made great inroads, and we're picking up these lesions very, very early. And added to this, there's a high incidence of congenital heart disease in IVF, though it's not been highlighted. And multiple pregnancies, low birth weight, all these combined perhaps has made it a little higher incidence than what was seen by our predecessors. So what are the challenges to managing these children? So there's a series of challenges at every level in the NICU, anesthesia, surgery, perfusion, postoperative course, and also if they require a cardiopulmonary support. And not to undermine this, it's a great team effort because the surgeon is only one cog in the wheel, and the surgeon has to be assisted by a whole lot of subspecialties, starting from the neonatologist, including the perfusion personnel. Now, when we are evaluating these small babies, neonates, sepsis is one thing which is paramount. They may also have immunodeficiencies, syndromes, and influence of other anomalies in the other organs, non-cardiac anomalies, which finally influence the results. And when we are evaluating these kids cardiologically, there are some areas where the surgeon has to take them up with a little question in his mind. One is the adequacy of the ventricles, adequacy of the AV valves, the LVOTO and the aortic valve. There are a lot of formulae and all that which are available today but then none of them are truly accurate. They've got their own drawbacks. Size of the pulmonary veins, especially when you're doing the total anomalous pulmonary venous connections and the arch anatomy, at least this we can, with reasonable surety, get a good anatomy by CT scans. So the decision-making process in these small children, small babies, generally is a team decision because a lot of multidisciplines are involved in taking care of them. So the cardiologist, surgeon, perfusionist, anesthesiologist, intensivist, and the neonatologist, I think the neonatologist plays a pretty big role in management of these children. So a joint review of all investigations, assessment of all syndromes, parental counseling, and more importantly, at least in a combined meeting, anticipate issues which could arise in the course of the surgery and recovery of these babies. So what are the risks of waiting and letting the baby grow? So if you see the article by Mohan Reddy, who's published in one of the issues of Pediatric Cardiac Surgery Annual, infections, gastrointestinal ischemia, because most of these kids have a duct-dependent circulation, either it is ischemic or it is steel from the GI tract, unstable hemodynamics or worsening pulmonary status. All these could give problems and they have not shown to result in better clinical outcomes. So when you wait with these lesions in these children, they could succumb from any one of these. But there are certain times when we need to defer surgery or delay the surgery, particularly if there are very severe medical factors like active infection or organ dysfunctions, active bleeding, or when the lesions are not that very severe and we can get by for some period of time. Or if we find, this is very important, is the team's technical and systemic factors are not conducive for proper recovery of these very small babies. And one rule which generally we need to appreciate is single ventricle low birth weight babies have the highest mortality amongst all the other lesions. Now, coming to some of the surgical issues which I have seen in my experience of the handling these babies, a good plan is extremely important. The surgeon has to have the clarity of plan in his mind. Cannulation is another milestone when you are taking up these kids for surgery, of especially on bypass. We try and complete the dissection before heparinization, because if you heparinize and try to dissect, the whole planes get obliterated. And there is a high threshold of delayed sternal closure in these children because of myocardial edema and lung compliance reduction. And all the other factors as listed needs to be appreciated. And in the course of repairs, we always try to ensure tissue to tissue continuity and try to avoid use of as much prosthetic material as much as possible, mostly autologous material. And one practical tip, especially for the younger surgeons, is the aortic cannula in these babies is inherently obstructive, particularly in TAPVC children or arch when the arch is small. And at the end of the procedure, once things are a little stable, maybe that needs to be removed to reduce the LV afterload. There are some anesthesia issues. Foremost among them have been prevention of hypothermia, because these kids are, so the theater has to be kept warm. And now we put these NIRS nurse electrodes to monitor the degree of perfusion to the brain. ETCO2 is a useful parameter. And of course, then there are the other tidal volumes, etc., which needs to be set accordingly. One of the most important and challenging roles in successful management of these small babies is perfusion. Because the surgeon and the perfusion team truly can make or break these babies in the postoperative recovery. So from the perfusion angle, what the perfusionists do is to miniaturize the circuit with usage of integral neonatal oxygenator, which are available now, least priming volumes by reduction of the tubing sizes. And many a time off late, we are now using graft cannulation of the innominate artery for selective perfusion. And this has truly changed the aortic surgery in these small babies. That avoids total circulatory arrest. And so therefore, the cerebral protection is pretty optimal. And if we have to use total circulatory arrest, we err on the side of intermittent total circulatory arrest. And that has given us, particularly with NIRS monitoring, a very, very good result. And most of the times we use aortic and just an RA cannula and then perform the surgery. The last point is extremely important for surgical perfusion because these children, we have to maintain colloidosmotic pressures and hematocrits at a most optimal level, or else you'll have a very bloated baby at the end of surgery. So some of the post-bypass issues we see in these children, the foremost amongst all these is bleeding because of the hemodilution, the tissues, and if the HP is very low, they could bleed a lot and consume a lot of blood products. One of the things I have learned is the lesser amount of blood products you transfuse these babies, the better are the outcomes. Myocardial edema and reduced lung compliance is always there in every child. And this is one of the reasons for a delayed sternal closure being higher in these children. So we do have sometimes desaturation and a higher alveolo-arterial gradient because of increased lung water in a few of them. Post-operative care, I think, is pretty exacting in these children. Foremost among these have been hypothermia, prevention of sepsis, having a good ID policy in managing these children. And of course, good nursing and nutrition go hand in hand in successfully managing these children. Our experience over the last 6 years has been in about 230 cases in babies 2.5 kilos or lower with a mean weight of 2.2 kilos, the youngest being 1.4 and the oldest being 2.5 kg. We have had a 15% mortality over this period in these babies. The spectrum of lesions, as you can see, is nearly a third has been in transpositions and total amylous pulmonary venous connections, next being arch interruptions and a few left to right shunts and hemitruncus patients. If you see the mortality by lesion, TAPVC seems to be the highest with mortality and TGS the lowest, with arch somewhere in between. Though our results are improving over the year, but still in these children, very low birth weight, the mortality does range in the region of about 9 to 10%, which is much higher than a full-term normal, full-term neonate. So the reasons for the mortality has been age at surgery, weight at surgery. Both of these are surrogates to the degree of sepsis seen in these children. Some of them had concomitant multiple left to right shunts, and few of them needed immediate reoperations, which also contributed to the mortality. So when we saw the reasons for mortality, 30 of these, majority of them have been sepsis. Either it has been sepsis preoperatively and we have had to move in quickly, or there have been postoperative sepsis with one bug leading to another bug to leading to another bug, which is commonly seen at least in some of these babies. So we keep on treating them with series of antibiotics. 2 had multi-organ dysfunction for low cardiac output, but interestingly, we didn't encounter any of the CNS issues in these babies. This is one of the examples of one of the smallest ones we have done, 1.4 kilos arch interruption with a large apical and multiple muscular VSDs. We had done an arch repair and a VA banding. And the VSDs to be closed when the child is a little bigger. So what are the lessons we have learned? This subset of low birth weight babies, it is a great team effort. All decisions on a realistic assessment of the team's experience and shortcomings, bereft of egos. That's most important. And we have to be humble enough to admit the true picture in a given setting. As far as possible, attempt a complete correction and avoid leaving behind any residual issues because they complicate postoperative recovery. And if there is any trouble, address surgical and other issues very early. And the cost in these children just skyrockets with every delay in decision making. The surgeon and the perfusionist are the two most important cogs of the wheel to smoothen out the postoperative recovery. And pulmonary artery banding is very difficult to assess the adequacy in these small children. So in conclusion, correction in low birth weight neonates is possible today with a pretty high degree of success. As I said earlier, complete surgical correction of the problem, leaving as few residual issues as possible. Hospitalization ICU stays are longer in these babies. Costs of care is much higher, and this cannot truly be offered as free care. Single ventricle palliations has its own set of problems and should be deliberated upon with the family before offering surgical palliation. I would like to conclude with a pretty provocative statement that in our setting, given the problems of resources, finances, living conditions, care and surveillance of complex multi-stage repairs, there may be a place for tender loving care management in selected instances, particularly if the long-term prognosis is not good or involves multiple palliative reinterventions. Thank you very much.
Thank you, Dr. Suresh. We can have a couple of questions for Dr. Suresh.
Good morning, sir. I enjoyed your talk. What I've seen, this kind of children less than 2 kilos, most of them, they have leaky capillaries, right? There will be edematous, there will be, second day or third day, irrespective of what you do on the theater with no residual lesions. I know the muff is the one, but how aggressive are in your ultrafiltration in the OTs, and how do you tackle these babies, especially if these babies goes into renal shutdown, even that matter get worse, right? PD and things like that. So it's almost impossible to get them back. So what is your advice on that?
Thank you for your question, Vijay. See, there are certain things which I would advise you to do to prevent this edema and renal perfusion. One is technically you should have a good venous return. If you don't have good venous return, the child will be bloated up. Second thing is colloidal osmotic pressure on bypass, either hematocrit or addition of albumin. And we are pretty liberal in these when we are doing these children. The third one, of course, is filtration. Everyone gets conventional ultrafiltration on pump and modified ultrafiltration thereafter. The other thing about renal failure, it's not been much of a problem. I have not seen that many. But the fact remains that if you are giving very high dose of inotropes, particularly the catecholamine, noradrenaline, vasopressin, I think you have to look back and see why you're doing that. I mean, if there's an indication, certainly. So, but otherwise, these children do have maybe transient renal dysfunction, but never usually progresses into failure.
Thank you, Dr. Suresh.
Two small questions, sir. Do you use PD routinely in this group of patients?
Sorry?
Do you use PD routinely in this group of patients?
We do see much more than what we were seeing earlier. And possibly because, you see, the thing is, the normal birth weight is 2.5 kilos in this part of the world. So below that, it's not very uncommon. We are seeing many more. And nowadays, with a lot of these multiple pregnancies, around 2 kilos is very, very, very common. Possibly because of IVF and all these other things.
Actually, I asked for peritoneal dialysis.
Right. Sorry, PD?
Peritoneal dialysis, do you use routinely or when the urine?
No,
output drops down, then you
no,
use-
we don't use routine. See, PD comes into picture, I feel, if you are getting repeatedly lot of edema in the child. Let us be very honest. Whenever you do a cardiopulmonary bypass on a small baby, there is going to be some ascites. But if it doesn't compress the cardiac, if it leads for you not to close the chest, those are the situations where you need to drain the belly. Otherwise, they do go into a period of low output, but they come out of that. Once it diuresis, all this goes off. So earlier I used to be very aggressive in putting PD, but off late, we don't use that much as what we used to do earlier. I think the central to all this is good perfusion.